Everybody, today we are going to talk about coronary artery bypass graft angiography. Some of you asked me to cover this topic, so we're going to be talking about the most practical things related to CABG as well as angiography. There's a lot of material in the books, textbook, videos, lectures about PCI versus CABG, the various kind of grafts, but we will try to stick to the most basic and practical things that you might not even find in any book or a lecture. So with that, we'll just quickly go over some of the indications for the CABG. As you all know, the indications for the CABG, if the patient's got left main disease, with the newer trials like Nobel and Excel looking into these patients who can also benefit from PCI with the left main PCI, but nevertheless still the left main, if the patient's got left main, CABG remains the preferred strategy. Yes, of course you can discuss with the patient as well. Another one is a 3-vessel disease if the patient has got triple vessel disease, or if they have 2-vessel disease in only if there is an involvement of LED. If it is only left circumflex and right coronary artery, then the PCI is a better option. But if you have 2-vessel disease, like let's say for example the circ and the LED, then you can discuss a potential CABG or coronary artery bypass graft with the patient. And of course, if the patient is going for any kind of a cardiac surgery like valve replacement or something like that, and they found to have obstructive coronary artery disease, then they might also get the CABG. One of the things that might help you in making a decision about a PCI and a CABG will be the diabetic patients. The Freedom trial and all the other trials, body trial, have shown that patients who have diabetes, they tend to do better with CABG as compared to the PCI. Having said all this, one thing you always have to look into is that if you are sending the patient for CABG, always ask your surgeon to place the LIMA. So left internal mammary artery to the LAD. And the reason for that is there is something about LIMA that it just stays open. There will be patients who will have bad peripheral vascular disease, carotid disease, femoral arterial disease, ischemic limbs. They might have subclavian stenosis, all the peripheral vascular disease you can think of. But when you look at their LIMA, for some reason the LIMA will be pristine. It is something about LIMA that it never gets any plaque. It's got a good flow, and that makes it the most preferred conduit or a bypass, and that's why they always put it on the LED. All the patients' native circulation, the vein graft, they might all get occluded, but if the LIMA is placed nicely, it stays open. And this is probably one reason that the surgeon, the CT surgery, are still in business, that the LIMA has some unique characteristics that it just stays open. So if you are sending your patient for a CABG, and if the patient can get LIMA to LED, that would be the preferred. If the patient cannot get a LIMA to LED for some reason, for example, the patient got breast surgery in the past, or they have radiation, and the surgeon say that they cannot use the LIMA, then the patient can be better off just with the PCI as well. And now, increasingly recently, there has been a push towards a hybrid approach where the interventional cardiologist can fix some of the arteries with stent, and then the patient goes for the CABG, or maybe the other way around. The patient gets a minimally invasive LIMA to LED, and then the rest of the arteries or obstructive disease can be managed with the PCI. With that, we come to the second portion, which is the conduit. So what are the conduit that the surgeons can use? By far, we know the most common is the vein grafts, just because they're readily available. LIMA, if the patient did not have previous radiations and other problems. RIMA, or right internal mammary artery. The surgeon can also use the radial artery. And not routinely seen now, but in the past, before the LIMA became more prevalent and the RIMA, there were some surgeons who were using even the inferior epigastric artery and extending it and trying to get it to the heart, but nowadays that's not done anymore. So with that, I would like you to look at this picture 1 here. So this is your SVG, or saphenous vein graft. So in the leg, it looks like this, and you see these small valves here. We all know that the veins have valves that allow only one-way flow of the blood. So when the surgeons, they harvest the vein graft from the leg, and they have to put it in the heart, or to bypass, to use it as a bypass, they stick this portion to the aorta and this to the target vessel. What they do is they flip it. If they don't flip it, then imagine if you just put this one like that and the blood has to go like this, the valve will close and there won't be any blood flowing through that. So what they do is when they put the vein graft during CABG, they flip it. They flip it, and that's why if you read the CT surgery reports, you will see that they will be very descriptive and say reverse saphenous vein graft. So this reverse, the word reverse comes from because when they harvest the vein graft from the leg and they have to put it in the heart, they flipped it so that these valves and the one-way valve in the vein graft don't obstruct the blood flow. Some other thing that I thought might be interesting. So with that, we come to the physiology here, the third portion of the talk. So talking to the conduit, we talked about the conduit. There are different kind of conduits, and we already covered that the LIMA is probably the best that stays open. The vein grafts, they are not very good, but still we use them a lot. If you look at this picture in these statistics in the middle, the 1 year patency of the vein graft is 90%. Imagine if there are 100 patients going in for a CABG, and then they come out after getting a CABG, about 10 of those patients within a year, they will have an occluded vein graft. Some of the experts even say that even before the patient comes back from the operating room back into the ICU or the recovery area, about 5% of their vein grafts are already occluded. So why don't the patient get a massive heart attack? For obvious reason, because they still have that native coronary artery circulation, although having severe obstructive disease, but still allows the blood to go through. So you don't see these vein grafts presenting with acute MI. But nevertheless, one thing to kind of remember that within a year, about 1 out of 10 vein grafts will be occluded. And if you extend this to 10 years, the patency still keeps going down. Depending on which literature you read, it can be somewhere between 50 to 60%. So after 10 years, the about half of the vein grafts will be occluded. And after beyond 10 years, there is a rapid decline in the patency of the vein graft. But what I want you to look at that is the LIMA. I draw a box around that. So LIMA has a patency of about like 90%, 90 to 95% in some reports. So even after 10-15 years, if the LIMA is put in nicely with good targets on a good LED, it can stay open for the rest of the patient's life. And that's why when in the beginning of the talk I was saying that if you're sending a patient for a CABG, ask your surgeon if they can give a patient a LIMA to the LED, because that's going to be a deal breaker. So with that, we come back again to this portion here, the physiology, left lower corner. So this is your conduit. It can be arterial or it can be venous. So the body of the conduit will also dictate if the graft will stay open or not. Again, as we talked about, the arterial graft will stay open longer than the venous graft. Another thing that is important is to consider is the inflow and the outflow. So the success of a vein graft or an arterial graft lies in three things: the inflow, the body of the graft, and the outflow. If any of these three have problem, there are chances that the graft will go down. So what do we do about inflow? So inflow, obviously, if the sutures are placed nicely and the anastomosis is good and there are no kinks, there will be good blood flow going into the graft, and there are more chances of the graft to stay open. And then of course we talked about arterial versus venous, and then we have to talk about the outflow. Again, if the anastomosis is really good, there is no stenosis at the anastomotic site, that will be dictating the outflow and also the native flow. If the surgeon is putting the graft on an artery that is diffusely diseased with diffuse disease distally, there won't be that much of outflow. And if there is not that much of an outflow, the chances of the graft to stay open will be low. So with that, we come to this picture here. So here I have tried to see, this is your native coronary artery and this is your graft, and they suture that with a native artery. So for example, if the patient does not have a significant stenosis, let's say for example 60% or 50%, if the surgeon puts this graft on this coronary artery, there is so much blood going through that native circulation that it will compete with the blood flow that is coming from the graft. So what will happen is slowly and gradually there will be stasis, clot formation, and the graft will go down. In other situation, let's say for example here in the native circulation there is a very tight stenosis of like 90%, so there won't be that much blood going through the native circulation, and more blood will come from the graft, and the more chances for the graft to stay open. So that again, as I said, goes back to the outflow that we were talking about. And for this reason, sometimes if you have intermediate lesion, we can consider doing an FFR in these patients to truly define if that lesion is physiologically or hemodynamically significant. So with that, we come to the picture 3 here. Here we will be talking about angiography, especially in the cardiac cath lab. So if you see this picture 3 here, it's just a little cartoon. What I wanted to stress is, in the cath lab, when we are doing diagnostic or interventional procedures in the cath lab, including PCI, we always say, well, when you are doing a coronary angiogram, you need to know the anatomy, you need to know your equipment, you need to know your catheters, your technique, because you don't just fish around for the angiogram or the coronaries, because the more longer you stay in the coronary circulation or inside the body, there are more chances of complication. So that is for diagnostic cardiac catheterization or the PCI. There is an exception. When we are doing angiography for patients who have CABG, you will have to fish around. I know it might sound a little funny, but I will get back to that, because what your good surgeons might have done is that they might have put 3, 4, or 5 grafts, and you just have to fish around for them. There's no, I couldn't find a better word to describe that, but yes, you don't know where the anatomy is, where they put the graft. Maybe the patient might have grafts 20 years ago and you don't have any clue. So what you have to do is you just have to fish around. Your catheter might be your hook, and you just keep fishing around until it hooks the graft, just like the hook gets the fish. So with that, we come to the picture 4 here. So here there is 1, 2, 3, 4 grafts. For sometimes the surgeons might put these radio opaque rings around the graft. I have shown that as a yellow line, so that might give you a clue, okay, where the grafts might be. But Not all the time you will find very good surgeons or helpful surgeon that they will put these rings. So what you have to know is, we know that the vein graft to the right coronary artery will be on the right side, and on the left side you will have the grafts that going to the circ or the diagonal. What the surgeon usually like to do is they try to place the graft, the lowermost graft, going to the diagonals or the LAD if they're not using LIMA. And then as you go to the circ or other artery, they go sequentially up. So for example, if you engage a graft and that is going to the circ, so now you know if there is a graft to the diagonal, it's probably be a little lower than the one that you already find. Some of the tricks that you might pick up while you do these angiograms. Here there is another artery that I'm showing here. It's a LIMA, right internal mammary artery, and here you have the LIMA, left internal mammary artery. In order to engage the LIMA, we use the catheter, which is a LIMA catheter. Next time when you are in the Cath Lab, try to look at the tip of the LIMA catheter. It's got a little hook on it. And that is because when you put this catheter here, it has to look downward, because the LIMA comes down, vertically comes down from the subclavian, as compared to sometimes you'll be lucky to engage that with a JR, but JR is a little opened catheter. So if you really want to engage the LIMA, you need to get a LIMA catheter, which is a little different from the JR because it's got a hook that can find the left internal mammary, and you can get a nice picture. One thing in all the books in intervention as well as diagnostic catheterization guidelines is that have a respect for LIMA. When I say have respect for LIMA is because the ostium of the LIMA is very, very fragile. I know we do it all the time. We do angiogram diagnostic as well as intervention, but in all the textbook, all the experts, they say have a very, very great respect for the LIMA or the anastomosis. Don't manipulate too much, because this artery can dissect very easily. Another point is sometimes the patient might have LIMA going to the right coronary artery, and you might ask, why don't they use LIMA going to the LAD and LIMA going to the right coronary artery? Why they use vein graft? That is because if they use the LIMA as well as the LIMA, and as we talked about that most of these patients are diabetic, what happens is that kind of cuts off all the blood supply to their chest, and there is a problem with the wound healing. So if you are using LIMA and LIMA at the same time, their external wound might not heal well. They might get complications, infection, things like that. So for this reason, the surgeons don't like to use both the LIMA and the LIMA at the same time. They leave the LIMA so that the chest wall has and the sternum has adequate blood supply to kind of heal the wound. Another catheter that you can use if you're not able to engage the vein graft, sometimes we use the JR, is LCB. You can ask your tech to get you an LCB, which is a left coronary bypassed graft catheter, or the RCB, which is a right coronary bypassed graft. So with that, we come to here the picture 5 here, and this is what I was talking to you about, fishing. So you have to just fish around. So here there are 3 grafts, 1, 2, 3. Your good surgeon did not put any rings. The patient had CABG about 20 years ago, and now he's getting an angiogram with you. So all you have to do, as I said, you have to fish around. So you have this LCB or RCB catheter, and or maybe a JR catheter. You just make it go up and down. There's no science behind it. You just move it up and down, keep clocking or counterclocking till you hook on to something, and then you take the picture. So as I said, the surgeons have distorted anatomy. They might have put the graft somewhere. All you have to do is just to fish around, go up and down, move the catheter up and down, and then clock or counterclock to kind of find or hook on to a graft. Of course, when you are doing this, you do tend to have a small risk of stroke. You can scrape a plaque, you can scrap a plaque, and that can go into the carotid arteries, especially when these patients are older. So with that, we come to the last three pictures. I want you to look at picture 6 here. So when you are doing an angiogram, you know that you don't see the proximal coronary circulation. You don't see any left main in these patients because they have bypass. You might not be able to, trace their artery all the way back to the left main to see, okay, which artery that you are doing an angiogram. So when we are doing coronary angiogram in these patients, let's say, for example, you engage a vein graft and now you're injecting the dye. One thing that will help you is your angle. And we have covered this in the previous, angiographic talks. So basically what you want to do is you ask your tech to move the camera to an angle where you know where the artery will be. So for example, in this, you ask the tech to move the camera to the RAO caudal view, and as we said, the caudal view is good for the circ. So you will see this artery here, and if the vein graft is filling this artery and it is the area where you think it should be, so that's how you say, okay, this graft is going to the left circumflex, or the OM in this case. LIMA, usually very easy. You are engaging the LIMA, and by far about 90 to 95% of the times it goes to the LAD, but you can still recognize the LAD with the septal perforator and the mustache pattern that they divide. So coming back to the picture 8 here, you see now you have this vein graft and it's filling some artery, and you don't know about this artery. It can be, let's say, for example, left PDA, it can be the OM1 or OM2, you don't have any clue, or it can even be the LAD. So again, as I said, if you know your views, then you can make up, okay, which artery the graft is going. So in this condition, or in this picture, you ask your tech to move the camera to the LAO cranial view, and we know that in the cranial view or the LAO cranial view, the LAD is going like this. There will be septal perforator, and the diags go like this. So if you see a branch that is filling by this vein graft in the RAO cranial in the middle of the picture, then you can say, okay, this is going to the diagonal, because otherwise you will not have any other way of knowing, because you don't have any other way of tracing the artery back to the left main. So I hope this was helpful. Do let me know if you want me to cover any other topics. Be happy to cover that too. Have a good day.